October is Facial Pain Awareness Month. I'm Anna Williams with Cluster Busters. We are an organization that researches, educates, advocates, and raises awareness for people who experience cluster headache. Facial pain affects our community as well because of the trigeminal nerve that is involved in a cluster attack. We collaborate with the Facial Pain Association so that we can raise our voices together to help patients.
Hello, and welcome to the Patient Q&A, the multidisciplinary approach to treating facial pain. I am happy to welcome Dr. Stephen Chang, Professor and Vice Chairman of Strategic Development and Innovation at Stanford University, and FPA Medical Advisory Board member. Dr. Meredith Barad, Clinical Associate Professor of Anesthesiology, Perioperative, and Pain Medicine, and Clinical Associate Professor of Neurology and Neurological Sciences at Stanford University. I'm Brandy Underwood, and I'm the Marketing and Communications Manager for the FPA, and I'm joined by our CEO, Melissa Bombick. Before we get started, I'll ask that attendees submit questions using the Q&A feature on your screen. We'll get to as many of your questions as we can over the next hour or so. Dr. Chang, Dr. Barad, please take it away.
Welcome, everybody. We are here to answer your questions tonight. I just wanted to start and set the stage by giving you a little bit of an overview of how we approach facial pain at Stanford. We all work together at Stanford. It's a really symbiotic relationship between our pain division and our neurosurgeons and our ENT doctors and our orofacial plastics team. And so when a patient comes to Stanford initially, they usually start in the pain clinic where they're evaluated for their pain. They have access to our pain physical therapists, our pain psychologists. They have access to a dentist who works with myself and the rest of our other orofacial pain doctors. And we pursue strategies like medication management and peripheral nerve blocks to help the patient manage their pain. And then we try to develop a better diagnosis. Oftentimes, these patients have never been seen by a specialist. They've never been seen by somebody who has experience with facial pain. And so based on our experience, we can triage our patients pretty well to determine if they should go to see the neurosurgeons or if they should go to see the ENT doctors or if they should go to see the orofacial plastics doctors. And so, and sometimes we all work together to try to figure out the best approach for the patient. So today we have Dr. Chang with us. He's going to talk about some of the really, really large variety of neurosurgical options that we have at Stanford. But I wish that we had all of the rest of our team here to discuss it as well. We can answer questions about a lot of different approaches. So yeah, even though we're only 2 members of a very large team, we can tackle it all. Steve?
Great. Thanks, Meredith. As Dr. Barad indicated, we have a comprehensive facial pain program. And what that means is they have specialists across all the various disciplines to provide optimal care. And sometimes that a patient may be very straightforward. Other times it might be complex. But the advantage of having a comprehensive facial pain program is that you have all the disciplines available to present all the options to the patients. So as a neurosurgeon, on the surgical side, I see patients that either come in to me directly or that Dr. Barad and her team will send over to me. If we feel the patient is generally failing medical management, we typically start with non-surgical treatments. And by the time a patient sees me, usually they've exhausted a fair number of the medical options, and or they're having too many side effects from the medications. And so then depending upon the type of pain they have, we'll walk through a variety of options. I'm a big believer in presenting all the options to the patient and presenting all the pluses and minuses of each option, and then helping the patient kind of understand, what the expectations are of each of these options, because no two patients are going to be exactly the same, and two patients with the same constellation of pain syndromes might choose different options. And as long as they're perfectly reasonable options, we're here to help the patient. So in general, the first step that we try to figure out on the surgical side is to determine the category of facial pain. Many of you may have trigeminal neuralgia. Other of you may have non-trigeminal neuralgia types of facial pain, or atypical facial pain is how they're commonly referred. And the separation of the patients into those categories really allows us to hone down the options that are available for the patient, and to set the expectations in terms of success rates of these outcomes. Typically, the discussion will center around what we see on an MRI scan. An MRI scan is commonly obtained in facial pain to rule out very rare causes of facial pain, such as a brain tumor or an old stroke or multiple sclerosis. But oftentimes we're looking for what's called a vascular compression syndrome. And if MRIs are very good these days, that oftentimes it will tell us if there is a blood vessel in contact with the nerve. And this is important in terms of how we approach the options. If a patient has very classical trigeminal neuralgia symptoms, the sharp electrical shock-like pain that come and go, and they have a vascular compression or a blood vessel touching the nerve, we often will talk about a microvascular decompression. That is a treatment that has been tried and true and usually provides durable results for patients, meaning if it works and your pain goes away, it generally persists for the lifetime of the patient. There's other options that we can discuss with the patient, including the use of radiosurgery. Radiosurgery is a generic name to deliver focused radiation to the trigeminal nerve, and it essentially, you're trying to damage the pain fibers in the trigeminal nerve so that they can no longer conduct the pain. The radiation option is an outpatient, non-invasive treatment, and it can be repeated multiple times if the first treatment provides results but then wears off. The third group of options that we usually discuss with the patient falls under a category called a rhizotomy. And a rhizotomy uses generally heat instead of radiation to try to damage the pain fibers of the nerve. But in other cases, you can use alcohol or even just a mechanical compression. We call it a balloon compression, but essentially it's a mechanically putting pressure on the trigeminal nerve to alleviate the pain. So there's a variety of different options you can discuss with the patient. We factor in things like other medical comorbidities, the age of the patient, whether they're on any blood thinning type of medications, all that kind of goes into the mix. Now, if we feel the patient doesn't have classic trigeminal neuralgia and has more atypical type of facial pain syndrome, some of these options are still available for the patient. The success rates may not quite be as high. And so again, it's a matter of setting the expectations in terms of outcome. So in terms of what we can expect in terms of the success rates for classic trigeminal neuralgia, the microvascular decompression, the radiation, and the rhizotomy all start out at about 90% initial success rate. The difference comes down to durability. The surgical procedure tends to be the most long-lasting, potentially even lifetime cure of the pain. The radiation and use of heat or alcohol to damage the pain fibers of the nerve generally doesn't potentially last as long. And the reason for that is the body has a good healing process that can occur. And when you create damage to the pain fibers, the body doesn't know that the damage was done for a good reason, and it tries to repair the pain fibers. So that's kind of the simplistic explanation for why sometimes pain can disappear and be resolved and then come back over time. So the microvascular decompression doesn't have that kind of general healing process because you're not damaging the nerve to start with, but the other procedures do. So what might be good for one patient might not be the best choice for another patient. And it's really the goal of the program to provide all the options to the patient and discuss the pros and cons of each of the options. So Dr. Barad, do you want to tell us a little bit about how on the non-surgical side, how you approach kind of evaluating a patient, and maybe, you know, when do you decide a procedure might be the better route to go?
Sure. So we'll take a really full history and full exam and really try to look at the patient, not only their facial pain, but all of their pain experience initially. So if we have a patient who has a very clear-cut trigeminal neuralgia, then classical trigeminal neuralgia, then we usually will refer over to neurosurgery directly because the success rates for classical trigeminal neuralgia and surgery for that disease are so high. But that's really the only type of facial pain where we have that great of a success rate. The rest of the types of facial pain, we don't have any surgeries or procedures or medications that have as much of a success rate. So we try to employ a combination of things. We'll start off with medications, and we can certainly discuss the variety of medications that we use at the center. We can certainly try some nerve blocks, either peripheral nerve blocks, starting right at the very distal nerves, the nerves that are at the very ends here, and try to figure out if there's any nerve injuries that might be problematic. We'll work with our dentist to determine if there's anything intraorally that's going on. We'll work in the sinuses to see if there's any sinus issues that are going on. And then we'll also look at how the brain is handling the pain. And so your experience of pain is dependent on how your brain processes pain. And your brain can process pain. Sometimes the brain can inhibit the pain quite easily and put a cap on it and be done with it. And sometimes the brain cannot inhibit the pain for a variety of reasons, and the pain keeps getting dialed up and dialed up and dialed up. And so we work with the patients on a variety of strategies, both pharmacologic strategies, but also psychological strategies. There's a lot of good research that shows that we can learn strategies to help modulate the way our brains process pain. And we have a whole team of pain psychologists in our center that work with our patients, that teach them through classes and through apps and through one-on-one sessions to learn strategies to help modulate the pain. Not necessarily a cure, but modulation. And then we have a lot of interesting research that is going on throughout all of our departments to try to figure out some strategies, some novel strategies such as transcranial magnetic stimulation or deep brain stimulation in the neurosurgical department, or there's a lot of interesting novel types of research that we're looking at Stanford for facial pain. So did I answer your question, Steve?
Yeah.
Okay.
I think one of the questions that comes up, Dr. Broad, is how's the kind of thought process in terms of managing a patient that has good pain relief on medication, but has a lot of side effects that they're experiencing? When, how do you handle that patient? Because their pain's under pretty good control, but they may say they're feeling tired, or they're not able to, they're sleeping a lot. Is that a situation that you commonly see, and really what's your advice on that?
Yeah, I mean, that's a very difficult situation. And what we have to have is a conversation about what is the right time to have a surgery. So if Dr. Chang says, okay, I think you're a surgical candidate, the patient may not want to do that right now if their pain is controlled or if they're able to manage is on the pain medications. But there might come a point when they don't like the side effects that they're experiencing and they would like to consider surgery. So for every patient, it comes at a different point in time, and it's just a careful conversation. I'm always happy to work and rework and try to adjust and tinker to try to find the right medication strategy. And oftentimes we can, but sometimes we just hit a wall, and that's when our surgical colleagues, that's when we can rehab the conversation. But usually what I like to do is just say, let's go to surgery right away and have the initial conversation. If you don't want to have any surgery or any surgical procedures, you don't have to, but at least we're all connected. We all are on the same page, and we can move forward together.
Mm-hmm. Mm-hmm. So generally, I like to, when I see a patient for a surgical procedure, I kind of try to assess not only just the pain, but their quality of life. I think patients with, facial pain, like most forms of severe chronic pain, have a number of lifestyle modifications that they either consciously or subconsciously put into play. If you have very bad facial pain, you might not want to do a lot of outdoor activity if the wind triggers your pain. You may not want to do a lot of international traveling if you're worried about being far away from home and not having, ability to see a doctor if you have a flare-up of pain. So I try to figure out how much of their quality of life is being impacted, and it sometimes can be. I think patients often don't realize how much modifications to their lifestyle they do in terms of managing their pain. Because usually, if you have a conversation about this and ask them very specific questions, like, are there things that you used to do that you don't do? Are there hobbies? Are there, I use travel a lot because I think a lot of people are scared to travel very far when they have face pain. And you'll find out really how significantly impacted their life is. And I started thinking about this because in patients that did have procedures where the pain went away, they were shocked at how much better their quality of life became. And so that made me kind of think about that as being one of the key decision makers in terms of whether or not to do the surgery or not. The decision tree on which one of the procedures to actually do, I'm happy to cover that in any of the questions, but generally, as Dr. Barad indicated, if we think the patient is a good candidate for the procedure, particularly if they're a younger patient, we like to go with a more durable procedures, one that'll get them pain-free for as long as possible. And that usually tends to be the microvascular decompression procedures. What we consider kind of a young patient has changed over the years. Microvascular decompressions now, we routinely do them in people in the 70s and 80s, as long as their quality of life is good and their health is good. Because even in that age group, if you can eliminate the pain, you can have a significant impact on quality of life. So I know we have over 100 people on the panel right now. If Melissa, in terms of their questions, how do you want them to field the questions? Do you want them to just type it into the?
Sure, they've been busy doing that. We have quite a few. So if you want me to go ahead and start asking those, I'd be happy to do that.
Sure, let's
Excellent.
go through those.
Okay. This subject came up in one of our earlier sessions, so I wanted to address it about burning mouth syndrome. And can that pain in burning mouth syndrome extend up from the mouth and to the nose and cheek? And what are the treatments for that?
It's not typical that burning mouth syndrome can extend up into the nose and the cheek. I mean, that's not something that I hear. I would think more about something coming from the sinuses or something coming from the sphenopalatine ganglion when I think about that, which is a little nerve bundle that lies behind the ethmoid sinuses and the maxillary sinuses. Burning mouth syndrome is a really tough problem. We don't have a lot of great solutions. It does seem to be due to some changes in more like a peripheral neuropathy, changes in nutritional levels. So nutritional deficiencies have been shown to cause changes in pain in the mouth. There is some thought that changes in estrogen around menopause can cause some decrease in nerve density and cause nerve pain in the mouth. So it seems like it's more of a purely peripheral nerve problem, and the solutions are tough. It's usually medication. We're looking at transcranial magnetic stimulation for burning mouth syndrome. There's some thought about in selected women patients, estrogen replacement therapy, and then making sure we're testing for all the nutritional deficiencies that can cause burning mouth syndrome and replacing those. But oftentimes it leads to a lot of significant depression and anxiety, and we see the levels of depression and anxiety much higher in patients who have burning mouth syndrome and atypical facial pain than, say, trigeminal neuralgia, for example. And I think that a lot of that has to do with the fact that we don't have as good of treatments for that yet. And so working with a psychologist to help provide support and some cognitive strategies for helping manage the pain can often be very, very helpful.
I've had this question a couple times about MVD after Gamma Knife, and is there a possibility that MVD might make the pain worse?
That's a great question, because for all these procedures, generally if one doesn't work, we can try another one. So it's not uncommon for a patient to say, I want to try a non-invasive procedure first, like a Gamma Knife or radiosurgery, and then if that either doesn't work or works for a while and the pain comes back, we can assess the patient for microvascular decompression as long as the MRI shows a vascular loop, a blood vessel that's touching or potentially indenting or compressing the nerve. Mm-hmm. So you can have quite good success rates with a microvascular decompression after Gamma Knife, as long as the surgical criteria are still there, which is, a patient in good health that can tolerate the procedure, a MRI that shows a vascular loop or blood vessel compressing the nerve. Those are really the two main criteria. Now there's some thought that potentially if you've had a Gamma Knife and you still have pain, that perhaps the microvascular decompression success rates might be a little bit lower than 90%. But if they are, that's not substantially lower. So that's still a good option as long as the appropriate workup indicates the procedural indication.
Okay. We have a couple questions about medications, carbamazepine in particular. After this particular question is about being on, how long can a patient remain safely on high-dose carbamazepine after this person had an MPD, but can't seem to pull back off of that drug without the reoccurrence of symptoms? And is there a concern there?
So how long can they be on the medication? I mean, we know this from the seizure literature that these patients can stay on these medications throughout their life. We do like to check labs from time to time, make sure their liver function is okay, make sure their sodium and potassium are good, and make sure their white count is good. So we do that, but most people people who get used to it. So there's like an initial phase where a couple weeks of bumpiness and some headaches and sometimes some dizziness. And then a patient is either going to fly, get used to this medication, be able to tolerate it, or they're just not going to tolerate it. It's usually one of those ones that we know within a couple of weeks if we're going to be able to use it. And those patients seem to do really well on the medication, unless ultimately as people age, all medications get harder, and we do need to try to taper down because their bodies are metabolizing medications more slowly as you get older. And so that can be a problem and something that we try to do very, very slowly in our patients that have trigeminal neuralgia.
Okay.
There was another part to that question that was, remind me.
Let's see, who's over here?
I do see a question here, like it doesn't seem like Tegretol and those classes of medications are helpful for other types of atypical facial pain. They're not as helpful as they are for trigeminal neuralgia. For trigeminal neuralgia, they seem to be exquisitely helpful for many patients, and sometimes almost that helps us make the diagnosis if we respond to those medications. And that part of that makes us think that helps us in our understanding and our research on the trigeminal nerve, and perhaps there is some change in the sodium channels of this nerve, or that this nerve is particularly responsive to sodium channel blockers. But we don't see that same effect in burning mouth or atypical facial pain, or even other types of trigeminal neuralgia.
Mm-hmm. We have a couple questions about patients who are not candidates for surgery. Either they, if surgery isn't an option and they're having failed medical management, or if they're just not able to have an MVD, or the MVD was unsuccessful. What's the journey look like then?
That's a pretty, that's not an uncommon situation. So even if the MVDs are successful in, the majority of patients at a high volume center, we'll certainly see, 10 or 15% of patients that fail MVDs. Fortunately, we do have the other options available. And usually, at least my personal next approach would be to consider the radiosurgery. And the reason for that is that, both a rhizotomy and radiosurgery will seek to damage the pain fibers of the nerve by creating injury to the nerve. The radiosurgery seems to have a lower chance of inducing some numbness in the face on the side of the pain than the radiation. And just in my own personal experience, it's been that while both radiation and the rhizotomy, typically using, the heat, can have recurrence of pain down the line, the pain tends to be potentially more durable with the radiation option. So the good news is that we do have options available, and these options compared to the MVD are less invasive. So on one hand, if the patient, failed an MVD or had good relief for a while, but now recurrence of pain, we still have a path forward to offer the patient treatment. And if they're able to tolerate MVD, they can certainly much easily tolerate a radiosurgical procedure. The patients, even if they have to go the rhizotomy route, which is still a good option in many patients, while that typically is done in an OR type setting, it's not typically done under a general anesthetic like a microvascular decompression. So even a rhizotomy is a smaller procedure than a microvascular decompression. So this is kind of one of the advantages of having a comprehensive center that really offers all the options, because it's you don't have to kind of reinvent the wheel by having the patient go to another facility and start all over again with the history taking and understanding the background of the patient.
Excellent. You mentioned rhizotomy. Is the success of a rhizotomy or ablation any indication of potential success for Gamma Knife?
Yeah, that's actually a good question. So I would say they both achieve results for the same general process, which is trying to damage the pain fibers. Now, if if you have one or the other and you have a good result, that does tell us that in that particular patient, the concept of creating a lesion in the trigeminal nerve seems to be the path of success. So if they have a good result from a rhizotomy, and it lasts like several years or so, but the pain returns, certainly the repeating that rhizotomy or moving to a radiosurgical procedure where you're essentially creating the same type of damage to the pain fibers of the nerve, just using a different modality, it would be a reasonable option. Conversely, if they've had a rhizotomy without any pain relief at all, that actually would lower the probability that a radiosurgery would be beneficial, because again, it's the same type of lesion you're creating, just with a different modality. So if creating a lesion didn't work the first time, creating the lesion the second time may have a little bit lower chance of success than a de novo patient that's never had a procedure before.
We have a question about young patients who develop pain idiopathically, seemingly, trigeminal neuralgia and occipital neuralgia. In this particular case, the MRIs have come back clear, and there's a question about whether or not a smaller Meckel's cave on the side of the TN and ON could have any connection to the cause of that pain.
Okay, Meredith, do you want me to take a stab at this one?
Yeah, I have asked this to some neuroradiologists, and they haven't really. They say they see variety of sizes of Meckel's cave all the time, and that it really doesn't correlate. They never see it correlating with their trigeminal neuralgia cases. Steve, you may feel differently, but I also just want to separate out occipital neuralgia, which is, I think, very different than trigeminal neuralgia and a whole different conversation.
Yeah, to echo that, so occipital neuralgia, we definitely would carve that out separately. That's usually the occipital nerve in the back of the neck. It's a nerve that's not it doesn't come from the cranial nerves. It comes from the cervical nerves in the neck. But occipital neuralgia and trigeminal neuralgia can coexist in the same patient, and it's important to kind of recognize when a patient has both. Similarly, you can have trigeminal neuralgia and geniculate neuralgia, trigeminal neuralgia and glossopharyngeal neuralgia. They can all overlap, and sometimes not recognizing that the patient can have more than one syndrome can result in kind of under-treating the patient. You treat one but not the other, and the patient still has some residual pain. Getting back to the question of the MRI scan not really showing anything, that certainly we can see that from time to time, and essentially, we rule out a tumor on the nerve, we rule out a blood vessel on the nerve, but the patient still has pain, and those are a little bit more challenging patients to treat. Generally, we don't like to do a microvascular decompression if we cannot see any type of anatomic irregularity on the MRI scan in terms of typically a blood vessel. That doesn't, however, mean the patient's not a candidate for radiosurgery or a rhizotomy. The patient still is a candidate for that. It's just that it's always nice to know if we can figure out the actual cause of the pain, rather than to say you have the pain, we don't know why it's there, but we can treat it. So if we know the cause, we can tailor our treatments a little bit more. So without seeing any abnormality on the MRI scan, I would still offer the patient, a procedure. It wouldn't be an MVD, but we would offer the other options. We would probably taper back a bit the estimated success rates than we would otherwise quote a patient with a more obvious definitive lesion on the MRI scan.
Okay. For patients who had a successful MVD, you mentioned earlier that those tend to be longer standing and can last for long periods of time. If the pain does come back, say after 10 years, something like that, what type of surgery would you recommend at that time?
Great question, because this is also not too uncommon. If a patient has pain relief, let's say for 10 years after microvascular decompression, that tells us at least that the initial mechanism of pain seemed to be pretty well understood in that patient, and that they had relief, let's say, from a microvascular decompression. So if a patient's pain comes back, the first step I typically do is to repeat an MRI scan. Let's just see kind of what things look like on the scan. Sometimes you can see, there's still a blood vessel in contact with the nerve. Perhaps the first time is a clear-cut artery took care of that problem. Now there's a vein that seems to have, maybe it was thought to be not the offending vessel the first time around, and certainly it wasn't if the pain went away for 10 years, but now it's still there. You also want to make sure that, again, the patient hasn't developed some sort of benign growth or tumor over the 10 years that is now putting just physical compression on the nerve. It's unusual to see, in a high volume center, it's unusual to see really obvious residual blood vessels touching the nerve. Generally, the first time you're in there, you're able to, the segment of nerve that you're actually looking at under the microscope is fairly short. It's about ½ of an inch long. So you don't have miles of nerve that you have to inspect. You only have a small little segment, less than a centimeter. And generally, as I explain this to, the residents that I train, it's, you only want to go in there once if you have to. Open up the head and have to expose the patient to brain surgery. So if there's any question of any vessel being the cause of the pain, you take care of it at that time. So if you see three vessels touching the nerve, you don't just assume that's the largest vessel that's the culprit. You take care of all three vessels during the procedure. So that does make it, unlikely that we would recommend a second microvascular decompression for the patient if you've really cleared out everything that you can see. But we do repeat the MRI scan, take a good look, start from scratch. Is there a blood vessel compressing the nerve? More often than not, there isn't. We can see the little cushions, the pledgets that we put in on the MRI scan, and we can see they're in good position typically. Now, these patients are still candidates for the other procedures. So if the MRI looks good in the sense that there's no blood vessels compressing the nerve, I would then typically offer the patient either a radiosurgery or a rhizotomy. The fact that they responded to a microvascular decompression generally confirms more classic trigeminal neuralgia than the atypical types of facial pain. So that's still a good sign that the rhizotomy or the radiosurgery would have a high success rate.
Okay. There's a question about familial TN, which we had a support group, tried to have a support group on tonight, but the question is, my mother had TN and MS. I have TN, MS is currently unknown. What is the likelihood that my daughter could have it also? And is there anything to be done preventatively?
Meredith, you want me to take a stab at this one, Meredith?
Okay, go ahead. I'll add on.
Okay, so MS obviously is a familial correlation, and MS can be a cause of trigeminal neuralgia, and in fact, it's not the primary cause, but a very well known subset. I mean, under 5%, but a subset of patients with trigeminal neuralgia, it is from MS. So if there's a strong family history of MS, it may not be, it may result in a situation where, depending upon where the MS lesions are in the brain, the patients may look like they have some trigeminal neuralgia that, quote unquote, runs in the family. Other than that, I'm not necessarily aware of any kind of correlation. Dr. Barad?
Yeah, I mean, I think the familial TN is something that I have kind of heard talked about, but there's not a lot of great data other than like a case report here and there, like suggesting that it's happened. And I think maybe it's more likely due to MS than that two people have a vascular compression of their trigeminal nerve, and that's an inherited situation. So I think more work needs to be done to understand that a little bit better. And just to explain that the surgeries that the type of patient that we really look for surgery, the type of patient that does the best in surgery is somebody that has classical trigeminal neuralgia, and has MRI findings, right? We like to marry those to the symptoms and the MRI. Those are the patients that have shown really good success rates in all surgical interventions. The success rates get murkier when the phenotype, the presentation is different and is not clear classical trigeminal neuralgia.
That makes sense. Okay. Is it possible, there's a question about, I would appreciate comments on possible reasons why a trigeminal nerve block would make pain worse for several months. Is that something you hear about commonly?
I think it would have to depend a little bit more on the situation of the patient and what type of trigeminal nerve block. Was it a Gisserian? Was it an isolated divisional nerve block? And what was the patient's pain experience? This is why we really try very hard to look at the patient to determine the type of trigeminal or facial pain that they're having, and then talk to them about different strategies. If they have atypical facial pain, yeah, all bets are off. I mean, it behaves so differently in so many different people that I've certainly seen nerve blocks go south in those patients. If they have trigeminal neuralgia, the thinking is that, let's see here, I'm going to use my pen as an example. This has a little flower on it. But if you have a compression right here by the flower up at the brain, and I'm trying to do a nerve block way down here, my nerve block could just aggravate the pain. It's certainly not going to reach the nerve where it's compressed, and it may just stir the pot and create more increased signaling of the nerve. So that's the theory on why the nerve blocks don't really work for classical trigeminal neuralgia, or may not work. But then again, sometimes they do work. So I don't know. we just try to be cautious and really not try to come out of the gate we try to go least invasive to most invasive in a very logical, stepwise fashion with our patients.
Okay. This is a question on medication, actually. The question says, I haven't heard anything so far about the efficacy of antidepressants on either classic TN or atypical facial pain. Are those drugs worth trying?
For classical TN, the drugs that have been well studied are the trileptal and tegretol, so the sodium channel blockers, the gabapentinoids, which is gabapentin and Lyrica, lamotrigine, Keppra, and the muscle relaxants. For atypical facial pain, we do find that SNRIs, serotonin and norepinephrine reuptake inhibitors like Cymbalta, it's also known as duloxetine, or Effexor, also known as venlafaxine, that there is some efficacy for many neuropathic pain conditions with those SNRIs. We also use tricyclics, so amitriptyline and nortriptyline. There's benefit for those in atypical facial pain. And SSRIs they don't have a lot of pain benefit, but but they do help with this cycle that many people are familiar with of depression aggravating your pain and pain aggravating your depression, and that helping us get out of that vicious loop.
Okay. Do you find that there is a higher incidence of intracranial arterial variations in patients who develop TN or other cranial nerve disorders?
Great question. So that was, we don't know kind on one hand, we know if a blood vessel is touching the nerve, that's what we look for on an MRI scan in someone with trigeminal neuralgia. But the reality is most patients that have a blood vessel touching their trigeminal nerve don't have any pain at all. We have MRI scans all the time for patients that are getting, workup for non-trigeminal disorders like brain tumors or strokes and things like that. And we see their trigeminal nerve has a large blood vessel sitting on it. They're not having any symptoms there. There's been some people that have hypothesized that, is it because they're more tortuous or wiggly blood vessels or things like that have been the cause of this. And I'm not aware of any kind of true kind of, anatomic study that's really looked at this. Meredith, do you have any?
No, but I do. I mean, I'm just curious too, Steve. In your experience, when you look at the blood vessels, are they? It's not that the blood vessels aneurysmal or irregular in any way. These are just.
They look like normal blood vessels. They're just kind of in pushing on the nerve. Sometimes the nerve looks a little thinned out and discolored if the blood vessel is kind of rubbing on it and kind of bruising it. We can see that. The nerve is usually a glistening white normally, and usually where the blood vessel is pushing on it, they can see some sort of, it's a little bit more off-white, maybe kind of a repetitive type of rubbing kind of injury type of situation. But the blood vessels themselves look normal.
Okay. Dr. Barad, there's a question asking if you could repeat the names of the drugs that you just mentioned.
Sure. Yeah. Should I write them in the chat? Would that just be
yeah, that would be great. I want to ask you another question though. Okay. So maybe is cognitive behavioral therapy most commonly used for pain management?
Well, that used to be the only thing we had to offer was a CBT for pain. And a CBT, if for those of you who don't know, is it's like a manualized, guided sessions of pain management, where each session you're learning different strategies, then you go home and practice, and you come back and you learn another one. And nowadays we have some different ones that are really cool. We have something called acceptance and commitment therapy sessions. We have a lot of work being done in post-traumatic stress and its relationship to pain. And I see this in a lot of patients who've had facial injuries, facial trauma, head injuries, and PTSD and how that relates to their pain experience. And then we have a whole new world that's being developed on what we call brief pain inventories. So these are like short 2-hour classes that the patient can take and really develop some focus skills that they can take with them throughout their pain experience. And we've used these before surgeries to help prepare the patient for the surgical experience and for their post-op recovery course. And we've used them just to help patients get like a foothold on their, I don't know if, I'm sure many people can relate to this, but sometimes patients we just all feel like we're spinning out of control, overwhelmed by all of the pain. And yet our wait to get into the psychologist is going to be 6 months. And so what we're working really hard to do is to give patients short interventions where we can get them in to see somebody, to see a group, to access some pain psychology in a brief way, and continue to do more touch points throughout until the point where hopefully we can get them into some one-on-one therapy.
Excellent.
Yeah.
Dr. Chang, do you see when you are doing the gamma knife procedure, many patients that come out with the anesthesia dolorosa, and how often does that happen?
For those of you that don't know, anesthesia dolorosa is a different type of pain. It's more kind of a just really severe burning pain that bothers patients actually more than trigeminal neuralgia. So it's something where we try to avoid it. Fortunately, it's fairly rare. we've seen it on, we're talking about low single, like 1 or 2% of the time after radiosurgery, you can see anesthesia dolorosa, and it's almost always in patients that have had more than one radiosurgery procedure. So it's very rare, less than 1% if you've doing your first radiosurgery procedure, but more common if you're repeating radiosurgery. And it's, some patients get 2 radiosurgery procedures. There's a handful of patients, there's probably about 100 plus or so in the medical literature that have had 3 radiosurgical procedures. And each time you do the radiation treatment to the trigeminal nerve to try to knock out the pain fibers, again, your body tries to correct the damage. It doesn't know the damage was done for a good reason. So it tries to fix what it perceives as damage. And we know when things heal, sometimes they don't heal perfectly right. And I kind of always explain anesthesia dolorosa as your nerve, the pain fibers in the nerve are trying to heal. They don't really kind of get the right connections there. And that can kind of lead to this type of pain. And so obviously, if you repeat the radiosurgery multiple times, each time you repeat the radiosurgery, you're damaging the nerve, it's healing, you're damaging the nerve and it's healing. And the more often you do that, the more likely you are to result in some sort of mismatch of the healing process. But something like that is a reason why in most patients, if the indication is there, we usually recommend a microvascular decompression, because that procedure, it doesn't damage the nerve. We're not going in there just to create an outcome by injuring the nerve. We're trying to respect the nerve during the microvascular decompression and just find the offending vessel. So usually you can tell kind of the impact on the nerve based upon how much numbness the procedure generates. So with a microvascular decompression, the risk of creating some numbness in the face is about, only 5%. And with radiosurgery, it's 30 to 50%. And with the rhizotomies, it's 75 to 90%, for example. So creating the injury to the nerve to alleviate pain, you can kind of see a parallel impact on the non-pain fibers, which are the sensory fibers. And the more you're really injuring the nerve, the more you're likely to get the numbness.
Okay. What kind of surgeries, we're coming to the end of our time, so we'll just probably have another question or two. But what kind of surgeries, rhizotomies, or if any, are appropriate for bilateral TN? What would be considered atypical?
So bilateral trigeminal neuralgia, we can see from time to time. It usually starts on one side, and then the patient starts to experience pain on the other side of their face. My general way to work that up, at least from a surgical standpoint, if they meet the criteria for a procedure, whether it's surgery or radiosurgery, is I start on the side where the pain is more severe, and that's almost always the side that the pain started on. Interestingly, a fair number of those patients, if you can get the pain to go away on the side that it started on, the other side of the face gets better. And I'm not quite kind of really understood why that's the case. And maybe there's definitely some crosstalk on the sides when you get into the brainstem. And some of it may be a kind of a perception of pain that may not be true pain and be referred pain or some other type of pain. But generally I start with the more severe side. And then if they have, if that pain goes away on the more severe side and they still have residual pain on the opposite side, as long as it meets the same criteria, we have done MVDs on both sides of patients. We've done radiosurgery on both sides of patients. So the workup is still very similar. But I always try to start with the more severe side and the off chance that both sides get better.
Absolutely. Okay. Do you have patients who have tried the portable neuromodulation stimulator placed in the mouth for pain relief or for pain?
I've not had any experience with that. Meredith, have you had any?
Mouth. I'm not sure which one you're talking about. There's a vagal nerve stimulator that they're not really doing any work on TN, but it is for different aspects of headache and facial pain. cluster headaches, that's approved. There is, let's see, most of the ones that I'm aware of are for headache, but I will tell you that it's like a brave new world of external neuromodulation, so non-implantable neuromodulation. And I feel like every week a different one is coming out. And I think they're interesting. I think they have not a lot of side effects. And if the insurance rarely covers them, so you usually have to pay for them out of pocket. So I would just be discerning and see if a lot of them have like a 30-day money back guarantee. So maybe try one that's in that category if you're interested in exploring those.
Okay. Is peripheral nerve stimulation, is that the same thing or something similar?
Well, peripheral nerve stimulation is a small implantable nerve stimulator. And so far it has just been approved in the neck. So it has not been approved for the face. And sometimes people are doing them for, really end stage or for experimental treatments. But I think that story is going to be told on that story. Now, I think there's one other thing here that I want to separate out, and I've seen some of the questions, is that some people have nerve injuries, and we call those trigeminal neuropathies. So you got a football in the face and you have nerve pain after the infraorbital nerve has been damaged from that injury. Our approach to treat that is much different than a vascular compression at the base of the brain. And so PNS, peripheral nerve stimulation, is really good for nerve injuries and has been used throughout the body for other types of nerve injuries. So as soon as we get on-label use for above the chin, then that will certainly be explored. So that's coming down the pipeline, but it's going to be more for neuropathies rather than neuralgia.
Okay, that makes great sense. Well, we are just about at the end of our time tonight. So I really want to thank you both, Dr. Broad and Dr. Chang, for an excellent presentation and just sitting here and answering all of these questions. It's really been great. This is the last session for tonight. Attendees, I hope you'll join us tomorrow for a full day of educational presentations starting at 11 a.m. Eastern, 8 a.m. Pacific. We're grateful for your participation tonight. It's been really incredible. Please don't forget to visit our sponsor booths and let us know how things are going by posting on the wall. And we will see you tomorrow. Thank you both so much.
Thank you, everybody.
Good night, everybody. Thank you.